Assalamu alaikum. It's a great honor to be between all of you, and it's really heartwarming reunion with my old friends. And many thanks to all you who survived till now. You can stretch your legs if you want. Okay, I would like to talk about the anti-seizure medication. Do we still need more? And yes, it's anti-seizure. We're just controlling the seizure. We're not treating epilepsy, as Professor Nathan just said. And this session is sponsored by Inspire Pharma, but yet it did not affect any of its medical or scientific content. First, I'd like to highlight some numbers we all, most of us, acquainted with, that almost 50 million people all around the world suffering from epilepsy, and 80% of which are in the low-income and middle-income countries. And with proper diagnosis and proper treating these patients, we only reach 70% of these people reaching a seizure-free life, leaving us with 30% refractory to treatment. And these people are higher risk, maybe 3 times more risk for premature death, and not to mention the stigma this patient and their families suffer from. And Neurology 2017 mentioned the incidence rate of epilepsy up to 50 per 100,000 people per year. And they mentioned 3 countries as outliers, and one of which is Egypt. ASU government were having incidence rate up to 150 per 100,000 people per year. And this could be true because we have a wide variety of etiology could be incriminated in the cause of the epilepsy, but yet again, it could be overestimated because we do not have a proper registry, and we pediatric neurologists are to be blamed for not having a proper registry for epilepsy. Maybe too many to count. And epilepsy is not a distinct entity by itself. It's just an end, final pathway for a large variety of different etiologies. And we go back to the classification. I know the ILAs had proposed different classifications, but if we go back to 1998, we have partial epilepsy accounting for 60% of the patients, and in contrast to 40% of patients suffering from generalized epilepsy, leaving about 3% unclassified. And still we have many of which not controlled. Until the year of 2021, we still have a continuing burden of refractory epilepsy. 30 or 40% of people do not have a seizure-free life. And therefore, the answer to our question, we still need new anti-seizure medications to enhance effectiveness and efficiency and less pharmacokinetic disorders. And I'm sure you faced this slide many times today and yesterday, the ILA definition of drug-resistant epilepsy as a failure of adequate trials of 2 tolerated, appropriately chosen and used anti-epileptic drugs scheduled as mono or combined therapy to achieve sustained seizure freedom. Actually, pharmacoresistance could not be taken that literally because it takes a lifetime to try all the anti-epileptics or many anti-epileptics with mono or in a combination. So we have to focus on appropriately chosen anti-epileptics. And we all aim to have a seizure-free life, but usually this could not be easily reached. So its clinical effectiveness of the drug, it's not only seizure freedom or efficacy of it, it's more tolerability of the medicine. So 2 drugs having the same efficacy and same spectrum, we'd like to choose the drug with less side effects. And we want to do this so for a quality of life, for a school life, normal school life, with a friendship with his colleagues in school, and we need to do this as soon as possible. And to my surprise, when I was going through the literature that in US, there is a delay since the onset of epilepsy till the patient reaches surgery for those who are indicated for surgery is 22 years. And definitely when he reached this delay, they will be disabled and family dependent all his life. And since 1993, more than 20 anti-seizure medications entered the market. And this gives us more weapons to use as mono or polytherapy, and more potential for the personalized treatment that has never been greater. One of which is lacosamide. I think it's underrated medicine, the third generation anti-seizure medication with a new target for the sodium channels, being very unique and non-traditional targeting of the sodium channels by slow inactivation and resulting in stabilization of the hyperexcitable neuronal membranes and inhibition of repetitive neuronal firing. And to understand this mechanism, we know the sodium channels goes through three phases: the closed and open phase and the inactivation phase. And fast inactivation takes around a few milliseconds, where the slow inactivation takes from seconds to minutes. And the advantage of slow inactivation to reduce the long-term availability of the sodium channel for activation without affecting the physiological activity of the channel. While fast inactivation just terminates the train of briefer action potentials and more likely to interfere with the normal activity. So this very unique mechanism of action of lacosamide allowed a fast track for approvals, starting back to 2009, where it was approved for adjunctive therapy for patients with partial onset epilepsy for adults, and ended in 2021 approval for patients 1 month and older for partial onset epilepsy. And just mentioned Professor Abdelmonti used it off-label for neonates below 1 month. And 2017 and 2020, it was approved for children 4 years and older for partial onset epilepsy and adjunctive for generalized tonic-clonic seizures. And when we has a new drug and we just compare it with an old drug with first generation, for example, was having the same spectrum. So this paper is discussing the efficacy and safety and tolerability of lacosamide and controlled release of carbamazepine in patients diagnosed as epilepsy at the monotherapy. And this RCT is a double-blinded study, and they went through gradual titration after randomization by 1:1 by computer randomization, and increments go on slowly every 2 weeks until reach a steady state and maintenance state of seizure-free life. And after 6 months, they resulted into being the lacosamide non-inferior to carbamazepine in treating patients with seizures as class 1 evidence for efficacy of lacosamide as first line for patients with newly diagnosed epilepsy. Moreover, they found it is a very non-enzyme inducing anti-epileptic with a predictable pharmacokinetic profile and low potential for interaction with other drugs. And this gives us the favorable pharmacokinetics profile of this drug, being a fast and completely absorbed medicine. What we take, you will receive in your blood. It's a dose predictable and the dose proportional range. And it reaches a maximum dose plasma level after 3 hours after ingestion. And moreover, it reaches a steady state after 3 days of twice daily dose ingestion. And a half-life of 13 hours, explaining why it's twice daily. It's minimal cytochrome P450 interaction and low protein binding, making it low risk for drug-in-drug interaction. Metabolized mainly by liver, 60% by liver, and 40% excreted in the urine unchanged. And it's not affected by enzyme inducers and inhibitors. And it has no significant effect on other anti-seizure medication. Another desirable feature of lacosamide is it being available as intravenous formulation. So patients coming with a status epilepticus, we can begin already with a therapeutic dose, and after termination of seizure, we can shift freely to the oral dose because it is bioequivalent to the oral formulation, and having the compatible to other saline and dextrose and lactated ringer, whatever you can available. It is safe and tolerable, having mild to moderate side effects, dizziness, headache, and nausea, ataxia, and these side effects rarely reach to to discontinuation of the medication, and it mostly dose related. It appears usually with high doses of the drug. It is usually appeared during the titration phase and just disappeared during the maintenance phase. No effect on hematology, no effect on the chemistry profile, and the favorable, no effect on the cognition. All this favorable pharmacokinetics and minimal side effect let it be a very good candidate for combination therapy. And you can even combine it with other sodium channel blockers because they have different mechanism of action, and both block the sodium channel, but most of the anti-epileptics are by fast inactivation. Studying the efficacy and tolerability of adjunctive lacosamide in pediatric patients with focal seizures. And this study showed how we increment the doses, and we will talk about the dosing in details soon. We increment around 6 weeks after which we can reach a steady maintenance dose after 10 weeks, where the patient reached a reduction of the seizure. And after maintenance, we found that the overall satisfaction was in the favor of lacosamide in contrast to the patient on placebo, and even on the patient on combined therapy with other sodium channel blockers showed favorable outcome compared to the patient with placebo on the 50% responder rate or 75% responder rate. Some of patients, of course, went through seizure freedom, and other had exaggerated seizure frequency, but both were comparable to the placebo. And this takes us to the dosage. We start our initial dose with 2 milligram per kg per day, and we increase the dose by 1 milligram per kg twice daily to reach a maximum dose of 12 milligram per kg per day for patients below 30 kilograms, and sometimes reach 15 milligram per kg per day. For patients between 30 and 50 kilograms, they reach up to 8 milligram per kg per day. And those about 50 kilograms, they are dealt with as if adult patients, starting by 100 milligram twice daily, or 50 milligram twice daily, and then maintaining into 200 milligram twice daily. And if by any means your patient stops seizing at the initial dose, it's not because it is controlled by the medicine. Lacosamide therapeutic dose starts after 100 milligram twice daily. So it's just your good luck, or because he's supported by other anti-seizure medications. And of course, we are all concerned about our patient cognition function and EEG. And when comparing it to lacosamide, to the carbamazepine, it was again in the favor of lacosamide and no effect on the cognition and neuropsychological tests, whether computerized or non-computerized tests, and also a favorable EEG scoring for the background activity. Trying to see the effect on the EEG epileptogenic activity, we didn't find except a case report which show a reduction in the persistence and duration of generalized spike wave activity, and even disappearance of the hyperventilation-induced absence in one patient. Although our goal is to treat the patient having a seizure-free life, but other effects could be beneficial and could not be underestimated. And we are faced with many patients coming saying, I have the same frequency of seizure, but its severity decreased. And if I reach a degree like the patient having multiple seizures, but his generalized tonic seizures disappeared, then this patient, I saved him from pseudo, okay? Or even he has a faster post-active recovery or becoming shorter duration of seizures. All these are beneficial effects could not be underestimated. And usually patients respond differently to the same drug. And a patient not responding to drug 1 is not necessarily he will not respond to drug 2. And moreover, the side effects which appear in different patients on the same drug is variable between patients. And this takes us to the individualizing the treatment of different patients. And we have to move from the era of trial and error of the medicine to the era of targeting or tailoring the medicine to each patient. And this started by the biomarker. By definition, it's an objectively measured lab and test of physical sign used as a therapeutic trial or substitute for clinical meaningful endpoints. For example, for diagnosis of diabetes, I'm searching for blood sugar of hemoglobin A1C, or I need prostate-specific antigen in cancer prostate. I need a marker. Tell me this patient is epilepsy. Okay, I need something to tell me which patient will respond to treatment and which will not respond, and which treatment is individualized for every patient. I don't need my endpoint is my patient satisfaction or feels how he survives. So I aim for predicting the development of epilepsy condition and preventing even the development of epilepsy, and reserve the progression, cure the patient, and telling which patient will be pharmacoresponsive and which patient will be pharmacoresistant and which side effects will appear. And starting the idea of the biomarkers and this simple figure to understand how biomarkers are measured. And here the seizure threshold being intermittent, because the seizure threshold is not static, like I having seizures with a diurnal variation, or I having seizure variable during the menstrual cycle of a female patient. And here it is the epileptogenic abnormality, and maybe structural or metabolic or genetic. And here is the precipitating factors, which could be an external precipitating factor like photo-stimulation in patients who are photosensitive. And for seizure to occur, the epileptogenic abnormality and the precipitating factor should reach the seizure threshold. And when seizure threshold decrease, patient is liable for appearance of seizure. And most of the anti-epileptics now working to increase the seizure threshold. And by decreasing it more, it can be occur seizures without a precipitating factor, or just precipitating factor like in febrile seizures, or both again together, causing more increase in the frequency and more increase in the severity of seizure. And if an insult occurred here, it causes epileptogenic abnormality by different mechanisms. And these mechanisms decrease the seizure threshold to a level where it can meet the precipitating factor and seizure occur. And with the progression of the illness, the mechanism differ and change, and like gliosis, for example. And this increases more seizure frequency and more severity by decreasing the threshold more. And if we measure the biomarkers in different points of time, it will be the variable at different points. So if we measure the A would be different than B. And if we know which biomarker affects the patient here in C and have an intervention introduced here, this will cause increase in the seizure threshold and cure of the patient. While if we know which marker measured here and intervention do it earlier, it can even prevent seizure. The biomarkers having a potential target for biomarkers in epilepsy are altered neuronal function and by gene expression profile and protein products, and altered excitability and synchrony, maybe polymorphism of HLA and complements in cytochrome P450, cell loss and hippocampal atrophy, axonal growth, synaptic reorganization, neurogenesis, angiogenesis, inflammatory changes, and altered glial function by gliosis. And these potential biomarkers usually measured by maybe functional MRI or even MRI by hippocampal changes. And the pathological high-frequency oscillation measured usually by intracranial electrodes of EEG. Recent studies measured them with surface electrodes combined with the functional MRI, PET scanning, and transmagnetic stimulation, and even gene expression profile. Elagouza was not back from this, and this study tried to find a genomic predictors for lacosamide in response to refractory epilepsy, and it did, although the result was not so satisfactory and not satisfying the threshold for authors and our threshold, yet it's just one step in the road. And even the exome sequencing did not reveal a significant contribution to any rare variants of lacosamide response. So just one step, and the field is moving, and it's challenging, but not realistic. Another exciting research to detect epilepsy, as Professor Mahan just said, the smartwatches and maybe implanted EEG, yet it did not prove the cost effectiveness and impracticability. So to conclude, lacosamide is the third generation anti-seizure medication with a unique mechanism of action enabled the design of possible synergistic combination, usually exhibited fewer or no pharmacokinetic drug interaction with few adverse effects for better quality of life, safety and effectiveness of lacosamide for treatment of partial onset seizure has been established in pediatric patients 1 month of age, and attention turned recently to other approaches, including targeting glial cells, neuroinflammation, and genetic mechanisms. And this is our patient. He was just admitted for intractable seizure. His neuronal ceroid lipofuscinosis. He was admitted for more than a month with intractable seizure. When I just asked the resident to send me his drug history, I had this list, but this statement just caught my eyes. He was lacosamide introduced and he was controlled. So I felt it's a sign to add it here. Thank you.
بسم الله الرحمن الرحيم. والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم. Thank you very much, Professor Iman, for this interesting lecture. Any question? في البداية بحب أتقدم بخالص الشكر والتقدير لكل أساتذتي في وحدة أعصاب الأطفال في جامعة عين شمس، وتعودت سنويا أكون معاهم في المؤتمر. فشكرا جزيلا أستاذنا الدكتور حامد شتلة، أستاذ الدكتور حمد الخياط، أستاذ الدكتورة سحر، أستاذ الدكتورة أمنية، أستاذ الدكتورة هدى، أستاذ الدكتورة رشا، أستاذ الدكتورة رانيا، أستاذ الدكتورة إيمان، كل الوحدة وكل لهم كل الشكر والتقدير طبعا على very interesting conference فعلا يعني متميز كاركترستيك و achieving و يعني سنويا بقى نشوف فيه new advancement في المؤتمر. وبشرف يكون جنب استاذنا الدكتور طارق عمر واستاذ الدكتور خالد فتحي. It's my pleasure now to introduce the next speaker. استاذ الدكتوره رانيا شتلة، هي هتتكلم عن drug resistant epilepsy a way out.
السلام عليكم. طبعا نمتوا خلاص؟ تمام هنصحصحوكوا دلوقتي ان شاء الله. ايه ده؟ ناموا بقى في التلفزيون وش اخر الارسال. Okay, I'll be talking about the drug resistant epilepsy. This is the agenda.